endoscopy, you know all, two-dimensional view, loss of depth perception, counterintuitive movements with rigid and no articulated instruments, loss of eye-hand coordination, and bad ergonomy. So robotics is the good way for many reasons: intuitive motion, 3D HD vision, hand-of-wrist instrumentation, and wall console capability. Just a slide about the optic. We use essentially the 3D 12mm optic, 0 or 30 degrees, and I will specify the utility of 30 degree for hiatus surgery, particularly. And instrumentation, we have 8 or 5mm instrumentations. But a study conducted by Quentin Ballouet from Limoges shows that for small cavities, he compared 5 or 8mm instruments, and he shows that 5mm instruments were space consuming. So actually, these instruments are reserved for thorax. For us, 8mm instruments are used for abdominal surgery. The Trocars positioning is very important, and you have to, this is for a kidney, but you have to delimit a semicircular line around the target. Accessory ports and robotic arms. This is a picture for my friend Mario Mendoza from Bellinzona, and it shows here the target and here's a semicircular line. We'll speak now about indications. This was a review made by Jan Chaussy and François Beckmer about all the indications with robotic surgery in a pediatric age. Our first publication in 2013 from Tours, we had made 86 procedures, a lot of urology procedures, 60%, but 40% were digestive surgery. And among these 40%, 30% were fundoplication. This is a very important slide. Indications. Reconstructive surgery is, for me, a better indication for robotics than for exeresis, maybe except for tumors or thoracic surgery. On this slide, you can show all the indications for abdominal robotic surgery which has been performed around the world, but some of them will not be detailed because in my mind they have no interest. So I will not speak about cholecystectomy or splenectomy because I think there are no good indications for robotic surgery. We will focus about fundoplication and gastrostomy. We will focus about LR myotomy and surgery of colorectal cysts, and a little focus on anorectal malformations. But you can see that there is some indication for colic surgery, LADS procedure, and duodenal atresia. I have personally no experience about these kind of surgery. So we will focus about Nissen fundoplication, Oesophageal Achalasia, hepatobiliary tract malformation with hepatico-jejunal anastomosis, which is a very, very good indication. I will not speak about colorectal non-bariatric surgery because I have no experience about bariatric surgery, but it can be performed with a robotic approach. So fundoplication is, in my mind, a good indication, particularly for small children and for reduced surgery. The limit is for me 6 kilograms, but there are publications under 6 kilograms. It's very important to use a 30-degree optic for this kind of surgery. We can perform the fundoplicator with or without gastrostomy. And you can see here the placement of trocars, the optic in the umbilicus. You have to delimit the median line in order to place the gastrostomy at the end of the procedure. And here's the trocar for the robot, one accessory port on the left and one accessory port, 5 millimeters, on the right, subcostal, to retrieve the liver. So we published with the Limoges team the first series of fundoplications we made in 2 centers. There were 60 patients. Mean age was 8 years and follow-up was 5 years. The indications were classical and there were 19 gastrostomy associated. The results were good. There was 9 patients, 15% weighted less than 10 kilograms, and the mean operative time was longer at this beginning of the learning curve, 127 minutes. Actually, this operative time is about 45 minutes, docking included. So you can show on these 3 periods the learning curve with the docking time, 12 minutes, 5 minutes, 4 minutes, and the operative time through these 3 periods. Interestingly, we have no difference with hospitalization stay between laparoscopy or robotic surgery, because robotic surgery is a laparoscopy. You can see here the learning curve with, in blue, the docking time, and in red, the operative time. There were 5 redo procedures, and I think this is a very good indication to use the robot for redo procedures, because you have adherences and the anatomy is a little bit different. So in conclusion, for this kind of surgery, I think this is a good indication. It's safe, feasible, but equal efficacy to laparoscopy procedure. It can be a good procedure to train the team for robotic surgery and to maintain the training of the team of robotic surgery. A little focus for patients weighing less than 15 kilograms. This is another study conducted by our both teams from Limoges and Tours, published by Quentin Ballouet in 2015. You can show here the conversion rate. Under 5 kilograms, 28%, between 5 and 10 kilograms, 5% of conversions, and no conversions below 10 kilograms. And you can show here for these 3 procedures for fundoplications, the setup time, the total operative time, and there is no difference between laparoscopy and robotic surgery. You can show here our experience with small children, group A, under 15 kilograms, and the blue one below 15 kilograms. And this is a global learning curve with the weight at surgery on the left and the time, and with the learning curve with the weight lower here than at the beginning. So now we'll talk about myotomy, which is in my mind a very, very good indication. That's another study conducted by Quentin Ballouet and by both teams from Tours and Limoges. Why is it a good operation with robotic? Because there is, for this procedure a risk of mucosal perforation with laparoscopic approach. So with the robot, you can have an anterograde or retrograde myotomy, and it is a tangential dissection with a limitation of the perforation risk of the mucosa. This slide shows a picture of the LR myotomy. You can show here the mucosa and the muscular, and after that we perform a classical fundoplication. This is a case of Limoges team, a girl from 3 years old with a gastric volvulus, emergency open surgery, and 2 recurrences. The indication for gastropexy and pyloroplasty was concluded, and the procedure was performed by robotic approach. And another case interesting is a gastric duplication. There are good indication for robotic approach because the dissection is very precise and fine. And my friend Laurent Fourcade had an original case with a trichobezoar. It was a 12-year-old girl with abdominal pain and distension, and the CT scan showed vegetal material in the stomach. He performed in emergency gastrotomy, and he emptied the stomach with an endobag. Now we can have a focus about colorectal cyst and hepaticojejunostomy. It was our initial experience. We presented this experience in Vicenza in September 2019. It was a Limoges and Tours experience, beginning of our experience. This is a challenging procedure because the anastomosis is complex and the dissection is also complex. So robotic surgery may be a very good indication for this case. We were 4 surgeons. We had a conventional pediatric laparoscopy, but no experience in laparoscopic biliary surgery and no experience at the beginning in robotic surgery. So these cases were done with no experience in robotic surgery at the beginning, with no experience with laparoscopic biliary surgery previously. Surgical technique: 8mm robotic instrument port, a 12 camera port, 0 degree, and 5mm assisted port. So the colorectal cyst dissection is performed very easily with a perfect vision of the cyst. You can see here the pancreas, and here the low choledoch. Just in front of the pancreas, you have to cut and separate the pancreas from the cyst. And after that, resection of the cyst and the accessory biliary, and then cut the cyst and open the hepatic duct with the robotic instruments. After that, the anastomosis is done with an open way by an umbilical approach, and then the last time is performed laparoscopically with the robot with an hepaticojejunostomy. This morning, I performed a case with a 6-month-old boy, and the operative time was 4 hours. But at the beginning of our experience, the operative time was very, very long because we performed the anastomosis of the bowel laparoscopically. So it's a good way to perform it with an open approach. results. The median age was 2 years. Operative time was very long at the beginning of our experience, and length of stay was 11 days, and follow-up 5 years. We have 3 complications: 1 angiocolitis, which resolves spontaneously, 1 bile leakage with conservative treatment, and 1 anastomosis stricture with percutaneous dilatation and a good evolution. So I think it's a very good indication. Anastomosis stricture may be prevented by no ductal inflammation and a good caliber for anastomosis. This has been shown in multiple publications. This series from Korea showed bile leakage was equal to open surgery. There was no statistical difference. And operative time was longer for robotic surgery than open for surgery. So in conclusion, for this indication, I think it's probably the best indication for abdominal surgery for children. I have no experience for inflammatory bowel disease, but adult team have experience with restorative proctocolectomy with ileal J pouch anal anastomosis. But in pediatric surgery, I think laparoscopic is better than robotic surgery, but maybe someone has an experience. Last topic, the anorectal malformation. High anorectal malformation. We conduct a neonatal colostomy because be careful with the placement of the colostomy because you have to place your port for laparoscopic approach. This is a delayed pull-through, and we can conduct a laparoscopic approach or Peña procedure. The fistula may be bulbar, prostatic, or vesical. I think for bulbar prostatic, Peña procedure is a good approach with long-term follow-up, which show us that it was a good procedure. But for prostatic and vesical, laparoscopic approach can be a good choice. And in this case, robotic approach allow a precise dissection of the rectum and a good dissection. So I think it's interesting to use a robot for high fistula, vesical or prostatic, because it allows precise dissection of the rectum and a controlled pull-through under direct vision of the perineum. It should be considered as an alternative approach versus Peña procedure in selected case, but for this time we have no results concerning long-term results for the moment. I will not speak about tumors because it's a topic of Thomas Blanc, but this is just a slide to thank my friend John Meehan, who showed us the way for robotic surgery, and he published this robotic surgery series for pediatric tumors in 2013. And this is our first series, but now Thomas Blanc in Necker Enfants Malades has a very great experience for pediatric tumors, and I will not speak for him. This is example of thoracic, of abdominal tumors performed by robotic surgery. So in conclusion, good indications should always be discussed compared with the laparoscopic approach in terms of benefit for the patient. Robotic abdominal surgery is easy to perform above 6 kg, a little bit difficult under 6 kg. So for neonatal surgery, I have personally no experience for robotic surgery, but some teams have experience, particularly for abdominal atresia. And reconstructive surgery, the better example is colorectal cysts, are, in my mind, very good indications. Thank you very much.
Thank you very much.
If you want, we can complete by the video of Laurent Fourcade showing a colorectal cyst operated with a robot.
Okay. Thank you very much, Hubert.
This is the video.
Okay. No, now we don't see. Now we see the your laptop, but not the video.
Okay. And now?
Okay. Now we have the video.
Okay.
Okay. Now work well, please.
Please.
Okay. Work well the video. If you want, speak.
Okay. This is a dissection of the. Laurent, tu veux commenter ou?
As you want.
This is a dissection of the cyst. You see the pancreas here, the duodenum, very precise dissection, very easy. Hemostasis is done step by step with monopolar scissors. This is a puncture of the cyst in order to facilitate the dissection, the end of the dissection. And after that, the dissection is completed under the hepatic convergence. You can see the common channel. You cut the common channel and you see from inside the level of resection of the cyst. It's very important to be careful not to cut too high, and it's very important to resect the most possible of the cyst. After the exeresis of the cyst, you complete the exeresis of the gallbladder, and after there is an open time for the bowel-to-bowel anastomosis outside of the abdomen. Here you see the cutting of the level of the common duct. The gallbladder. You prepare the bowel and you perform the anastomosis between the bowel outside of the abdomen. And after that, a new laparoscopic time. The bowel is passed transmesocolic. The loop is opened with the monopolar scissors. And a terminolateral anastomosis is performed on the loop. And for children of 6 months age, is very easy to perform. Maybe we can stop the film now. You have a precise view of the operating field and a nice anastomosis. Thank you. Thank you, Laurent, for this nice video.
You're welcome.
Thank you.
Thank you for your attention.
Thank you, Hubert, and thank you, Laurent, for these very interesting cases and very good video. Now we open the discussion. Any question?
Hubert, thank you for these great images. I would like to ask you, how do you manage? You can imagine to perform the same operation with the other instruments. You know, the 5 millimeters, which have 3 centimeters of rotations. It means the ancient instruments, because at the moment XI doesn't allow, they don't have the permission to use the new 5 millimeters. They don't exist. It means that I had experience with a similar case, and I found at that time when we performed the first case of choledical cyst, it's a case very similar to your case. In an infant, it was maybe more than 1 year of age. We used the 5 millimeters instruments, the oldest one, and they have 3 centimeters of rotation. In this way, you can pull up the lever with the rotation. So at the same time, you can pull up the lever and perform the anastomosis. It is circular anastomosis. It's wonderful. So I want to know, how do you pull up, well, with these instruments, the lever, and how you perform the rotation with these instruments in a very small space?
I have no experience with these kind of instruments, but the lever is retracted by laparoscopic forceps of 5 millimeters, and we suspend the round ligament, and the gallbladder is useful also to retract the liver. And we have no experience with 3 millimeters instruments, and I think Laurent Fourcade has experience with a liver retractor, which is very, very interesting. But Laurent has this experience, I have not.
Thank you.
Laurent, what is your opinion?
Yes, I think that what said Gloria is very, very useful to use the beginning of the instrument to up all the structures. But for this case, we use the Nathaniel retractors. That is we are using a 5 millimeter port to pass it to the skin. And once it's in place, it's very useful, it's very convenient, and you can bend it to the size of the child. So, but we have to book it especially for this intervention. It's very expensive. But I think for the time of the future, it's very useful, because even if you use the techniques of Gloria, when you retract your instruments, you lose the hanging of the liver, and you have to go back and to lose time to take the theater, the localization of the liver and of the anastomosis, and you can make some injuries with the needle inside the liver. So I think the retractors seems to be useful, but we also use the techniques of Gloria with the beginning of the arms to hang up all the structures.
Thank you, Laurent. Now, Professor Tovar, and after Ernesto Leva. One.
Thank you, Mario, and thank you, Hubert, Laurent. I am always very impressed by your achievements in robotic surgery. And I have a question about, how do you envision training in robotic surgery? You think that younger people that start robotic surgery should be fully trained in laparoscopic surgery before, or can they have both trainings at the same time, robotic and laparoscopic or thoracoscopic surgery?
Alors, Laurent will complete my response, but I think that pediatric surgeons must be trained for open surgery, for laparoscopic surgery, and for robotic surgery. It's very important because you can convert from robotic to laparoscopy, and you can convert from robotic to open or laparoscopy to open. So they have to be trained for 3 kinds of surgeries. It's very important in my mind.
Okay.
Laurent?
Yes, thank you, Juan, for this question. It's really a key point, because if you see the experience of the adult for the prostatic robotic surgery, they are going directly from the open surgery to the robotic surgery, and they omit to train and to do the classical laparoscopic surgery. And we thought it was the same with the pediatric surgery, and we did some few studies with medical students. And in fact, what you are learned with the robotic surgery is not transposable for classical laparoscopic surgery. So like Hubert, I think that we have to learn the 3 techniques: open, laparoscopic surgery, and robotic surgery. But it will be a challenge in the future, because I think that hopefully with the time, the robot will be democratized for all the hospital. And for the young surgeon, it's really easier to do robotic surgery than laparoscopic surgery. So we have to do to build some curriculum, and we have not to omit classical laparoscopic surgery.
Thank you, Laurent. Now, Ernesto Leva.
Yes, thank you very much for your presentation. I have 2 short questions. One is concerning anorectal malformation. And the question is, do you think that this approach should be also indicated for those type of cloaca malformation where the fistula is very high in the dome of the vagina? And the second question is concerning the anesthetic management of the patient. Have you seen any difference in terms of anesthetic management and post-op pain between robotic and laparoscopy? Thank you.
Thank you for these interesting questions. For the first one, we are organized in France for surgery of cloacas in 3 or 4 centers. So in a case of cloaca, we don't operate in tools cloacas. So I have no experience for cloaca with a robotic approach, but I think it's maybe a good indication, but I have personally no experience about that. For the second question, for the anesthesiologist conditions, the anesthesiologist said this is for us just laparoscopy. There is no difference. The only difference is to be very, very, very careful with the installation of the patient, because they have no access to the patient during the procedure. But the procedure is for them a standard laparoscopic approach. The only difference is concerning the postoperative pain. The patient have less pain than for laparoscopy because the trocar are not growing in the abdominal wall. So this explains the difference between the laparoscopic group and robotic group.
Thank you.
Thank you. Laurent, you have a...
I have nothing to add. I don't have the experience of cloaca in Limoges, but I think that we can say that the more higher is the fistula or the communication, the more easier it will be possible to do this kind of surgery. But most of the time you have a colostomy or something like that, so you can a little wait to do the surgery up to a weight for the child up to 8 or 10 kilograms. For the anesthesiologist, they said for them it's very boring because there are nothing to do once the surgery began. But like said Hubert, at the beginning, you have to really involve them, and I will show you that later with the thoracic approach, with the robotic thoracic approach. You have to involve them at the beginning of the program, otherwise they will be very scared, but they have no way to be scared, in fact.
Thank you, Laurent. Now, I want to know what is the opinion of Adrian Bianchi, because for the anorectal malformation, the last year, one session of the master, I have anorectal malformation, and I do the pull-through with the Georgeson technique with the laparoscopy. One of teaching of the faculty in this period is Azad Najmaldin that say me to the dinner that, oh Mario, you have the robot and the anorectal malformation is a infant of 6 months old is ideal for this indication. What is the skeptic opinion of Adrian Bianchi? This is your technique, the tapped. And we do laparoscopy, and now we won't do this with robotic surgery. Adrian, what do you think about this, please?
Well, you asked me to be purposefully critical, so I will try. First of all, we are not all so lucky to be able to have robots in the theater. So it is going to take a long time before young pediatric surgeons are trained consistently in robotic surgery. As far as anorectal malformations are concerned, my view is that if you want to complicate the condition further, carry on with increasing the numbers of robotic or laparoscopic approaches. Most of the fistulae can be reached from below with what I call the transanal anorectoplasty, the TAP, as Mario mentioned. And therefore, you do not need to go near the abdomen to enter the abdomen in any way. And if you do them in neonatal time, you do not need a colostomy. For those that are higher, where the fistula is at the prostate level, then laparoscopic or robotic, if you like, or open is necessary. The question of training and time comes in. The open is a phalansteal incision. You are straight onto the bowel. You can retract the rectosigmoid and follow it down very quickly, very easily. And within the space of 1 hour or so, you have completed the whole procedure. So there are these questions to consider. I have to conclude by saying I am not against laparoscopy. I never have been, or robotic surgery. But I believe that sometimes we are a little bit more interested in telling everyone how great we are with a new technique, and we forget the reality of life, that most people do not have the robot. And sometimes we forget the patient, so the patient has to suffer much longer operating time because we wish to develop our skills. So I think we should put the patient first as well. I will not say any more, Mario.
Thank you very much, Adrian. Giovanna.
Buon pomeriggio a tutti. Io credo che invece tra la laparoscopia e la robotica nella dissezione profonda della pelvi vi siano delle differenze. Sto facendo una piccolissima esperienza, ma devo dire che trovo che si lavori in maniera molto precisa. Quindi questo può essere sicuramente un campo molto interessante, soprattutto nelle forme più complesse, perché le malformazioni urogenitali le fai meglio per via robotica, e anche tutto ciò che riguarda il retto basso. Il problema magari può essere il peso del paziente, cioè se le cloacche noi sicuramente le operiamo un po' più avanti, in media intorno ai 6 mesi, e quindi il peso ci può stare, e anche l'ingombro del robot, forse molte malformazioni anorettali le operiamo 2-3 mesi, quindi sicuramente il bambino è molto piccolo. Vorrei porre questo argomento del peso nella malformazione anorettale dell'età in discussione, Mario. Grazie.
Puoi formularla ai relatori in inglese quest'ultima parte. Grazie per il commento.
Certo.
Dimmi.
So thank to all of you for your lecture, video, and the comments. But I think that anorectal malformation is a really very good indication for robotics, and the robotics give a lot of advantage related to laparoscopy in the lower part of the pelvis for rectal, urogenital tumors, and this kind of indication, in my opinion, are very good. My question is related to the weight and the age of the patients, because we used to treat cloacal malformation after 6 months of age, so they can be, a good candidate, but anorectal malformation earlier. What is your opinion related to age and weight of the patient for robotics?
Laurent and Hubert.
I think that for the abdominal procedure, it's quite different that from the pelvis procedure because it's not expandable too much, but around 10 kilograms, it's really feasible because you don't push too much the structures, and even if the size is large, 8 millimeters in comparison with 3 millimeter ports, the magnification and the precision of the movement will help you to do a better surgery. Under 5 kilograms, it's possible, but it's very challenging, and you will have some conflicts between the instruments. And like said Dr. Bianchi's, perhaps it's not safe for the child.
Thank you, Laurent. Hubert?
As I told, I have no experience for cloaca, but for anorectal malformation, we didn't change the age of the radical surgery, which is 4 months. And I thank you, Adrian Bianchi, for your remarks. I agree with you. The technology must never be placed before the interest of the patient. I completely agree with you.
Okay, thank you. Thank you, Hubert.
Posso commentare un momentino?
Yes, please.
Okay. Thank you. At least there is one person who agrees with me. I'm very, very glad to see that. What is your objection to operating on the child in a younger age group and without colostomy? I have never been able to understand why skilled, competent surgeons now able to do robotic surgery do not wish to adopt surgery during the early neonatal phase, where the surgery is much easier, much quicker, and does not require colostomy. Why wait 4 months and have to do a colostomy in the meantime? There are very good reasons from the point of view of continence and learning, physiological reasons, not to do a colostomy and to allow normal sensations from very early on. So, so much as I admire robotics, if it requires waiting for 4 months to do the surgery, then I do not feel I can agree that this is an appropriate technique. Quite apart from the actual operative method, which is a different thing. Thank you.
Laurent, Hubert, Laurent, please.
Yes, thank you, Adrian, for your comments. I have to say we never postpone or we never delay a surgery to specifically do robotic surgery. When I have to do a colostomy in an anorectal malformation, I will do whatever the technique I will use later. I think it's another debate. We have not, and you are really right, to modify the time of the surgery because we want to use a device, even if it is the robots. So I never postpone or delay the surgery for the use or to use the robot. I think it's not ethic, it's dangerous, and I'm totally agree with you.
Same response for me than Laurent.
Okay. Now, before they conclude the discussion, I want to know the opinion of Mario Mendoza and Pierluigi Lellichiesa. Mario, what is your opinion?
Thank you, Mario. I was thinking about the discussion for anorectal malformations. I was wondering, as these are small kids and technology for robotics is sometimes difficult to achieve, I would like to know some tips and tricks that maybe Laurent or Hubert can give about the tricks with the babies with colostomy, with the placement of trocars for the road to avoid collisions, and how do they deal after once they did the dissection? Because mostly I think robotics will be helpful to make the decision in the pelvic part, but then for the anoplasty and everything, they deduct everything, and they need sometimes to reduct, or they switch to laparoscopy then at the end to control things if they need to control things. Because I think this is something that also could be a debate, knowing that if a laparoscopic approach for this type of procedures maybe could that be quicker or safer, I don't know, if we are just doing dissection and not doing reconstruction, which is one of the main things for robotic. So what is the real place for robotics in anorectal malformations, for example, or the advantage besides a laparoscopy if it's mostly dissection?
Thank you, Mike. Okay, please.
For us, effectively, the dissection is performed robotically, but the pull-through and the control after the anoplasty are made by a laparoscopic approach. We don't use a robot for that. Laurent?
Laurent?
Yeah, it's also a matter of fact. Yeah, I think the robotic is good for the dissection, and then once you finish the dissection, you have to do the pull-through. And you are right. If you want to go back, you have to dock again, or just put the camera to check that there is no twist in your pull-through. But it's not very convenient, perhaps. I think that for more complex malformation, perhaps like cloaca, but I have no experience of this, robot will be very better than classical laparoscopic surgery. But for anorectal malformation, in comparison, it's very difficult to put the things in the small spaces. So I'm not, I think it's possible to do it. It's not dangerous for the child, but in comparison with the facility of the maniability of the camera, when you are going to the bottom, you are going to the belly, etc., perhaps with the classical laparoscopy, it's easier.
Thank you, Laurent.
Thank you very much.
Mario,
yes.
Scusa, un ultimo commento?
Sì, certo.
Laurent and Hubert, I think you have just made the case for why open surgery is easier than a very complicated situation of going in, doing a dissection, coming back out, doing a pull-through, going back in to have a look to see if it's twisted and such like. All of this takes time and particular skills as well. I just have to say that it is making a relatively straightforward operation much more complicated. I am trying to be skeptical, as Mario said to me. It's not that I don't like your techniques. I think they are very beautiful. But I have to say, I still would go for an open surgery for the child with the imperforate anus. We have to be very careful when we speak about anorectal malformations. I don't like the term, because we cannot mix cloaca with imperforate anus, with high fistula, with low fistula. You have to be very specific what you are talking about. But that is another argument. Thank you.
Thank you, Adrian. You are a positive skeptic, yes, because you are interesting to the Howard technique, really. Pierluigi.
Yes. So about why colostomy for anorectal malformation. So the first question of Adrian. I appreciate very much the comments of Adrian. but about, in my opinion, about a male with probable bulbar or prostatic fistula or bladder neck fistula, I think the colostomy is more safe than going in neonatal period directly from below. This is my opinion. Is of course is the opinion of people performing PSARP since the late 80s with good results, in my opinion. So first answer. Second answer, of course, in very high cases, bladder neck fistula, all the cloacas, I haven't a direct experience, but my opinion is that robotic or laparoscopic approach are better. Of course, also speaking, agreeing with Giovanna, the robotic approach for cloacas and the uterovaginal malformations, so the pelvic approach to this kind of malformations is absolutely better than laparoscopy and of course than open, in my opinion. About the age, same answer. The age before 3-4 months, we perform operations, first colostomy, second operation for male, about between 6 and 8 weeks of age, and we perform open. Robotic could be impossible at this age and with this weight. About cloacas, yes, we perform cloacas at 6 months of age, not before, and in such occasions, but of course cloacas are not usual malformations. In France, probably is correct, they try to centralize the series. I think nobody, if you not centralize the patients, your experience will be a good experience in 20 years. So next generation of pediatric surgeons. I think I conclude my comments.
Thank you, Pierluigi, for your comments. Now I ask to Gloria Pelizzo to introduce the second speaker. And before you introduce the second speaker, I want to remember all that I am recording the meeting, and Friday is possible to review the meeting in the website of our society, because this is possible for the colleague that is possible to have time to see, to follow this meeting. Please, Gloria.
Just before introducing Laurent Foucault, I want just to add a few words to Adrian, saying that it's true, robotic surgery and laparoscopic surgery needs a lot of training, but I think it's a good manner to see in a different way, different spaces, or better, the same space we usually see in open surgery. But it's important to have this in the mind of the new fellows, the young surgeons, another view of the same space under laparoscopic approach and robotic approach. Even robotic approach means a lot of different techniques in small babies. It means the docking process. It means go down from robotic, laparoscopic when necessary, and so on. I think this different view on small space is a new learning, a new approach, a new methodology to offer to students, to fellows, and to surgeons. I want to introduce Laurent. Laurent is a good friend, I think, of all of us. A good surgeon, a lot of training in robotic surgery, good teacher. Is working in Limoges. And it took part on a meeting of young surgeons at that time that started with robotic surgery, and actually is learning and teaching robotics as well with Hubert in France and in Europe as well. So it's a good pleasure to introduce Laurent.
Thank you. I will try to put my slides.
Okay.
But
Laurent, do you remember is the green button down the video, okay?
I push on it, but sorry for the delay.
No problem, no problem.
Yes.
You open before your presentation, and after, when you push to the red button, you see your laptop.
But the presentation is not on my laptop. There is a danger. No. Sorry for that.
Problem. If you want to do this, if you want time, we start with Thomas. Thomas is ready, Thomas?
Perhaps, but Paul is here.
Yes, I am.
Yes. If, Thomas, you want to start, please, because Laurent have a technical problem.
Thomas, if you can, it could be very helpful.
Je suis là, je suis là.
Gloria, probably you introduce the other speaker. Okay, microphone.
Thomas, with pleasure, is from the school of Necker, and a young promise of new generation of pediatric surgeon training and robotics. He comes from a great group of pediatric surgery in Europe with a good tradition in non-invasive surgery and good training and good tradition in pediatric surgery as well.
So do you hear me?
Yes,
yes.
we see your laptop. It's okay if you want to start.
Okay, thank you very much. So first of all, thank you very much for the invitation. It's a great honor for me. So I will focus my topic on two aspects. First, the retroperitoneal approach with robotic surgery, and then the renal tumors. I have no disclosure. So just to remind you, this the first review of the first decade of robotic surgery in children published in 2013, you can see that the urology in robotic pediatric surgery was really increasing at the end of the 2000 years. And at that time, there were only 137 publications, but you will see that things have changed. Recently, European Urology Focus published a review made by Anne-Françoise Pinault about the role of robotic surgery in children. And they stated that even if there are no randomized controlled trials available, the pyeloplasty procedure is the only robotic application where the European Association of Urology Pediatric Guidelines recognizes that in good and experienced hands, the open, the laparoscopic, and the robotic approaches have the same good outcomes. When you look at the literature, there are many papers about pyeloplasty. One of them, at the beginning of the experience, demonstrated that with time, you can decrease the operative time and you can decrease the hospitalization time. So it means you acquire expertise with laparoscopic surgery in urology. When you compare robotic assisted laparoscopic pyeloplasty and open procedure, now this comparison is not very well balanced because there's only 9 robotic and 61 open procedures. You can see that the age is totally different because usually you do robotic surgery in older children and you keep doing open surgery in younger children. Alors, I was very surprised by the operative time in the open approach. According to me, the advantage of the open approach for pyeloplasty in very young children, it's very short, but in this paper, it was quite long. And interestingly, robotic surgery was shorter than open surgery, which is not the case in my experience. So the drainage was different according to the approach because it was different according to the age of the children. The robotic approach was less painful and the hospital stay was shorter, and the complication, it was the beginning of their experience. They had more complications with the robotic approach than with the open approach. Another paper with 5 centers, only expert surgeons for infants. You can see that the mean age of the 60 infants was 7.3 months with a mean weight of 8 kilograms. You can see that even with expert surgeons, the procedure takes time. It was almost 4 hours of surgery with excellent results and only 2 redo procedures. But you have to remember that this paper deals with experts in robotic surgery. Alors, retroperitoneoscopy, we will talk about this topic later. Previously, the group of Henning-Olsen in Denmark was the only pediatric surgeon to use this approach with the robot, and they published their large experience in 2007 with 67 patients, only 1 conversion, quite short operative time, 230 minutes, and 4 redo procedure, which is a very good results. Recently, a very interesting paper highlighted that the number of pyeloplasty in the US goes down. You can see that in more than 10 years, the number of pyeloplasty have been reduced by 2. And when you look at the number of procedures performed either by open, by laparoscopy, or by robotic surgery, it's very different based on the age. In children younger than 1 year, you can see that 80% of the procedures are performed in open surgery. But for the adolescent, it's totally the opposite. More than 80% of the procedures are performed in robotic surgery. And you can see that laparoscopy is decreasing year after year. One excellent indication of robotic surgery is for redo pyeloplasty, because you have to work with scar tissue, and the quality of the dissection with the robot is very interesting for redo procedure. And this is the same arguments for to perform ureterocalicostomy when it's difficult to dissect the renal pelvis because of ureterocalicostomy, and with the robotic surgery, this is very, very interesting. You can do robotic surgery for a complex case of UPG obstruction, such as horseshoe kidney, ectopic kidney, renal malformation, duplex kidney, or failed UPG, failed repair. And you can see that even in these complex cases, Mean operative time was more than 3 hours, with an anastomotic time of more than 1 hour, and a short hospital stay, a good result, only 4% of preparation, with a short follow-up, of course. So I will show you our strategy in Necker. We have started the multidisciplinary robotic pediatric program in October 2016, 4 years ago, and we have operated more than 300 cases. And you can see that most of the cases are urology cases. So we use different approaches. We can use transperitoneal approach, and for kidney and adrenal surgery, we place the port in the midline. So 2 ports above the umbilicus and 1 port below the umbilicus. When you do pelvis or presacral surgery, we put the trocars at the level of the umbilicus. And as I am right-handed, I put 2 ports on the right side of the patient. And usually we put the accessory port in the pharyngeal incision. If you need to retrieve a tumor, it avoids to have another scar. We also use the robotic surgery for retroperitoneal approach. So you all know the lateral retroperitoneal approach. And thanks to Yves Loury, we have adapted the prone retroperitoneal approach to children with the robot. And we have done 6 cases. And for very specific indication, it's very interesting. So this is the indication for robotic surgery in the department. As you can see, the most common procedure is UPG obstruction. And interestingly, in blue, this is the indication that had never been done before in the department in laparoscopic surgery. It means ureterostomy. It's a very good indication with the robot because it's reconstructive surgery in very small ureter, very tiny ureter. So it's quite a very interesting indication. Detrusotomy. Professor Lotman in the department has a large experience of detrusotomy in open surgery. And he wanted to develop detrusotomy with robotic surgery, either isolated or associated with the Mitrofanov or ureteral reimplantation. Partial nephrectomy, I don't talk about upper pole or lower pole nephrectomy. It's lower pole and upper pole nephrectomy, we do these in laparoscopy. But for special indication, we have developed partial nephrectomy, and not for tumor, because I will talk about tumor later, either in retroperitoneal prone or in transperitoneal. Mitrofanov, I had never done before Mitrofanov in laparoscopy, but now we have experience in robotic surgery. I have done only once extravesical ureteral implantation because it was a bilateral case in an older girl. And we have done a vaginal reconstruction with ileum in a teenage girl with cloaca. And recently we have controlled the communication between the vagina and the urethra in an urogenital sinus. So first, UPG obstruction. So always the same question, which approach to choose, trans or retroperitoneal? Most of the people do the transperitoneal approach because you have a larger working space. But for me, one major inconvenience is you have the bowel, and there is a theoretical risk of intra-abdominal injury, even if it's very rare. Retroperitoneal approach, if you are comfortable with the approach.
Con le sterline.
Excuse me? Do you hear me?
No, yes, you listen. Spegnere il microfono, per favore, chi è entrato.
Oh, sorry.
Grazie. Please, Thomas.
So with the retroperitoneal approach, you have direct access to the urinary tract. You can, in case of UPG obstruction, you can easily detect the crossing vessels. By definition, you have no manipulation with the intraperitoneal organs. And in case of urine leakage, it will be self-limited. So the approach is a personal preference, but based on the experience of the individual surgeon, and each surgeon should be familiar with both approach and should be able to adapt the approach on the indication of surgery. So when I was a fellow of Alain Elgonemi, he trained me to the retroperitoneal approach. And I wanted to, so you all know the approach, it's a lateral approach. So I studied the expertise of Alain Elgonemi, and we could define three phases. The first phase is the phase number one, is the standardization of the technique, and it took to Alain Elgonemi 30 cases. Phase number two is the transmission of the technique to other surgeons or trainees of the department, but without any dedicated training program. 44 cases. And phase three, this is my 2-year pediatric urology fellowship program at Robert Debré with 30 cases. And you can see that in phase number one, you have the conversion. You have only one redo procedure and the operative time goes down. In phase two, there is no redo, only one redo, no conversion, and the operative time is even. And in phase three, this is my fellowship, you can see that the operative time goes up, but not as much as at the beginning of the experience of Professor Elgonemi, with no conversion and no redo procedure. So we have shown that this technique, even it's difficult technique, you can teach it to young fellows dedicated to this approach. So when we have started the robotic program in Necker, we have started fortunately, and we have the Trump table, which is very helpful. So I wanted to keep using the retroperitoneal approach to do kidney surgery. So first, I went to visit Henning Olsen in Denmark. I was not very happy because his way of doing laparoscopy for retroperitoneal approach was very different from my teaching. So I went to see Christoph Wesen. Christoph Wesen is one of the proctor of Intuitive in Europe for adult urology. And interestingly, he used to work in Toulouse in the pediatric surgery department. So he knows very well how to deal with small children. So Christoph came to my department. I was doing laparoscopic retroperitoneal pyeloplasty in a very small children. So we discussed together, and then we found out how to adapt the robot to the retroperitoneal approach, knowing that the trocar of the robot are 8 mm instead of 3 mm for laparoscopy. So trocar placement and patient positioning is very, very important. So your landmark are the costovertebral angle, the 12th rib, and the iliac crest. So first you will put the camera port. And once the camera is inserted, you have to create space. When you do retroperitoneal approach, you have to create space that is virtual. So you will at the back of the patient, and very gently, you will create this space. If it bleeds, you have no instruments to control the bleeding, so you have to be very gentle. Thanks to the adult, I use a needle to find out precisely where I will insert my trocar. So you can see the needle. So this is on the psoas muscle. So I will now insert my first robotic trocar. So you can see that the trocar are quite big. It's 8 mm, but you have enough space to insert it. Then you have to push the peritoneum medially. So you do it with your camera, with your 0-degree camera. It's very important to use a 0-degree camera. And once you have created this space, so this is the view from inside. So you push, you push, you push. You don't see anything, but you push, and you will be stopped by the peritoneum. You see here the peritoneum, and you will push it back medially to insert your second trocar. So I always use a needle. So the third robotic port is more medially, and you have space now to insert it. And you always need a bloodless field, because if it starts bleeding, it's much more difficult. And you have more space. You put your camera in the trocar at the back. And you will insert the assistant port. You don't need to put an assistant port, but just for safety, I prefer to add an assistant port. Dear seal. So this is the setup of the operating room. And then you can create your retroperitoneal space, because you have, so far you have no space. So the issue with the robot is not the diameter of the trocar, it's the length you need to insert your instruments to be able to take the control of the instruments. And at the beginning, the space is very small, so you need to be very careful when you insert your instruments. So the bipolar is inserted. Now I will insert the scissors. And the two instruments have to be close to each other, because when you will go to the console, you have to see your two instruments. So during the approach, the psoas muscle will be your landmark. You always have to know where is your psoas muscle. So you will open the gyrotest fascia. So it's now. And you will see the psoas muscle here. Okay? So then you will open widely the gyrotest fascia, and the air, the CO2, will be insufflated inside the gyrotest fascia, and the kidney will be lifted up upstream. So no bleeding. If it bleeds, you get lost. So this part of the procedure is the most difficult to teach to the fellow, because you can be lost. I remember very well that Juan Tovar came to visit me in Necker, and I was doing this procedure, and I got lost, and I was upside down because my orientation was not good. So at the beginning, you have to be very, very careful not to do any mistakes. So you create your space. This is a left, so you have the aorta, and then you will change your instruments. I am right-handed, so I will use the scissors on my right trocar. So I increase the space, the retroperitoneal space to the legs, and now you can start. So when you compare laparoscopic approach to robotic approach, laparoscopic approach, you have only 3 ports, 5.33 millimeter or 10.55 millimeter according to the age. With the robotic, you can do 3 trocar, but I always use to take any risk. So whatever laparoscopic or robotic approach, you do a blunt dissection of the muscles, you open the transversalis fossa. But was it different? With the laparoscopic approach, you open the gyrotest fascia under vision, then you insufflate inside the gyrotest fascia to push the kidney upstream, and then you insert the trocar in the gyrotest fascia. It's totally different with the robotic approach, because you create your space, you push your peritoneum, and then when your trocar are inserted, you open the gyrotest fascia. So it was the major issue at the beginning of our experience, because we had totally to change our habits. So whatever you do Anderson-Heinz dismember pyeloplasty with 6 OPDS. So only 2 papers have been published with the retroperitoneal approach in robots with Henning-Olsen. So we wanted to analyze the 2 first years of the robotic program in Necker. So in almost 4 years, we have operated 75 pyeloplasty, 17 transperitoneal for reduced surgery, horseshoe kidney, ectopic kidney, surgeon's preference for bilateral UPGO because of stones, and 58 retroperitoneal approach. And we have published in Frontiers in Pediatrics our preliminary results. So the median age was 8 years. The median weight was 23 kilograms. the youngest was 2 years and 12 kilograms. And I think it will be very difficult to go down to younger age and lower weights. So at the beginning, the setup time was time consuming because you don't want to make any mistakes, and it took time. But you can see that in custom analysis, after 15 cases, we could manage the setup time. The anastomosis time, at the beginning, it went down, but you can see that here, this is the time where the fellows were helped, and the time goes up, and this is exactly for the consult time, it goes up here. Because after 25 cases, the fellows are helped to do this kind of procedure. So interestingly, in the intraoperative course, 2 peritoneal opening, but no conversion. With this approach, you have no collision, no between the instruments of the port, no vascular injury. It was my major fear at the beginning. That's why I use an assistant port, because when you have a polar vessel, if it bleeds, you're in trouble. No positioning related injury and no emergency endocking. So 6 patients had UTI, but this is very common when you have a GG stent in pediatric surgery. In urology, 2 GG stents malpositioning, but the patients are symptom-free with decrease of dilatation, and so far, no redo pyloroplasty have been done. So this is the evolution of the dilatation in the postoperative course. And all the patients but 3, so 95% of the patients were discharged on day 1. And now we have started the day case program for pyloroplasty because it's a request of the family of the patient to arrive in the morning and to leave the hospital in the afternoon. Of course, the follow-up is still short with a median follow-up of 2.5 years. And we have to keep following this patient. So this technique, at the beginning, of course, it's a technical challenge. You have to be trained for this approach. The robotic instruments are bulky, but when you do the suturing, it's safe and effective, but we need longer term follow-up. What is very interesting is the training. The training is the major advantage of the robot. This is Professor Lotman. He's a 64-year-old surgeon, very talented, but for him, laparoscopic pyloroplasty was difficult. And after 10 cases, he was able to do a laparoscopic pyloroplasty with the robotic approach. So you can see that with this approach, you can see very well when you have no polar vessel here, or you can have, in some situation, you have 2 polar vessels, one anterior obstructive polar vessel and one posterior non-obstructive polar vessel. So you have to anastomosis anterior to the anterior vessel. So this is a very short movie of a pyloroplasty. So the ureter is spatulated. So you can do a large spatulation. Then you will open the renal pelvis. You have urine coming in the field. So the suturing with the robot is really a major advantage. And with you break less thread of 6 OPDS with the robot than you break them with laparoscopy. And then you do, so this is the most dependent part of the anastomosis. So this is the first part of the anastomosis. You can see that the anastomosis is dependent and the tissue are very well vascularized. So now our strategy for UPG obstruction under 12 kilograms, we do either lateral retroperitoneal laparoscopy or posterior lumbotomy. It's based on the surgeon's choice. More than 12 kilograms, we do robot-assisted lateral retroperitoneal laparoscopy. And in case of giant hydronephrosis, retrocavalier ureter, duplex rotation, it's based on the weight of the children. At any age, in case of ectopic kidney, horseshoe kidney redo, and bilateral, we do transperitoneal approach. So now I will talk about renal tumors. Just to remind you that pediatric cancer is a rare disease. And in France, for instance, we have 160 cases of Wilms tumor per year. As Hubert told us before, John Meehan in 2013 published a very interesting review, and he noticed that there there is almost nothing in the literature about a pediatric tumor with robotic approach. And 7 years after, things haven't changed very much because there are only few papers about robotic oncology in children. And interestingly, there are no randomized prospective studies comparing first laparoscopic non-cancer procedure with open and laparoscopic tumor resection with open. So there's no evidence base in the literature to do, could we do laparoscopic or robotic surgery for tumors in children? Recently, the umbrella protocol defined the criteria for laparoscopic management of renal tumors. And contraindication is tumor infiltrating extrarenal structure, tumor extending beyond the ipsilateral border of the spinal column, thrombus in the renal vein or the renal cava, and most important, little or no experience in laparoscopic nephrectomy. And you have to consider to do open surgery or to transfer the patient to another group. So as you noticed, we have done 75 oncological cases since the beginning of the robotic program. All the renal tumors were treated according to the SIOP 2001 protocol. And we have published recently our preliminary results. So this is the list of the 21 renal tumors we have operated so far. So 16 cases were for total nephrectomy, and they were operated with the transperitoneal approach. All the cases were Wilms tumor, except one sarcoma. So this is the port placement for the renal tumor. The port are in the midline. At the beginning, I used to put the assistant port in the financial incision to avoid an additional scar. But the fellows and residents told me during the procedure that the access is difficult. So now we put the assistant port at the level of the umbilicus. It's much more convenient for the assistant. So it's a transperitoneal approach. So you can see in this tumor, this patient doesn't respect the umbrella protocol because the border tumor goes beyond the border of the vertebra. And this tumor is almost 15 centimeters in a small children. So I will show you just the dissection of the renal pedicule, because this is the most important part of the procedure. So you need a bloodless field. It's very important. So you have to control very carefully any bleeding. So as in open procedure, we control first the artery. So we use Hemolock. I use a tourniquet to expose the vessel, to help me to expose the vessel. So this is the first renal artery, and you have a second one here. So to dissect the vessel, the monopolar curve scissors are very useful. So no bleeding. And once the artery are controlled, you can do the vein. So the vein is always more difficult. So first you put in proximal, and then in distal. I always put two Hemolock clip on the vena cava aspect. Here you check that there's no thrombus, and this is the final aspect with no drainage of the operating field. We had to convert 4 cases. The first cases was converted because of bleeding of the renal pedicule. It was a lack of experience. I tried to dissect the pedicule with vessel sealer, which is not a good instrument to do the dissection. So I controlled the bleeding with the robot, but I preferred not to take any risk. The second conversion was a sarcoma with a LOXO1 treatment, and the inflammation of the renal pedicule was very intense and very difficult. So I preferred to convert, and even in open procedure, the renal pedicule was very difficult to dissect. Third case, I will show you a video. It was an emergency undocking because my clip on the renal vein on the vena cava aspect went off, and with bleeding. So this is the first emergency undocking. And the last case, when I had to open the diaphragm to resect a part of the diaphragm, and the child tolerated very poorly the pneumothorax, and we had to convert. Interestingly, in one case of rupture at diagnosis, it was a left-sided renal tumor, and we noticed during the procedure that there was tumor in the spleen hilum and above the pancreas. So we decided to do en bloc. So this is the CT scan at diagnosis. You can see a huge tumor on the left side with uncommon liver metastasis. This is after the chemotherapy. You can see that the liver metastases are gone. And during the procedure, we decided to remove en bloc the kidney, a part of the diaphragm, the left, the spleen, and the caudal aspect of the pancreas. So the mean age of the patient of the children was 4.7 years. The youngest was 6 months. During the discussion before, the age at surgery was a point of discussion, and I think that even in very young children, you can do this approach, but of course, don't start with very small children. But now this is not a contraindication for us to do robotic tumors in small children. No rupture during our experience, except R0, except 2 spillage, 1 undiagnosed renal vein thrombus. Excuse me. The day before surgery, the patient had a CT scan that didn't show any thrombus, but once the procedure was almost completed, we saw a thrombus in the renal vein. We tried to remove the thrombus with the robot. I put a clamp on the vena cava, but unfortunately the clamp was in the thrombus, so we had to convert. And one other case, the case with conversion due to poor respiratory tolerance, the patient had a liver infiltration of the wings, so there is one second spillage. So no adjacent organ injury, 4 conversion, I told you, and 1 emergency undocking. So before, Laurent told us that for the anesthesiologist, robotic surgery is boring. It was my point of view until this case. So this case, it's a children with, you can see before chemotherapy, a very large wings. After chemotherapy, you can see the tumor is still big. And most important, the tumor is at anterior development. And you can see that the aorta is here and the tumor goes beyond the aorta. So this is the tumor. So I put my clips, my hemolog clips on the vein. So the first vein was controlled. This is the second vein. Usually I put 2 clips on my vein, but I had no space because of a very, very dilated vein. So I put only 1 clip. So very carefully, I cut the vein in between the 2 clips. So for this case, I asked Professor Sarnacki to go down to the operating room just in case of emergency. So I was okay. And I always use a gauze to remove any bleeding. And with the gauze, the clip on the renal vein on the vena cava slipped. So first you have to communicate very well with the assistant on the field with the anesthesiologist, and you cannot convert now. You have to control the bleeding first. So I took advantage of my gauze, but unfortunately it keeps bleeding. So I asked the nurse to insert a second gauze. So the surgeon at the console cannot leave the console, because if you leave the console, the robot doesn't work anymore. So you have to stay at the console and you have to communicate very well with your assistant. So they insert a second gauze and the bleeding stopped. So it took 12 minutes for Professor Sarnacki to do the open approach to control the bleeding. Unfortunately, no rupture of the tumor occurred. So it shows us that the surgeon needs to be trained, but the assistant, the nurse, the fellows, the resident, everybody needs to be very well trained, because when it happens, you have to know exactly what to do. So we have done 5 cases of partial nephrectomy in retroperitoneal approach, either lateral or prone approach. So 3 WIMS, 1 tubulopapillary carcinoma, and 1 nephrogenic rest with no conversion. So the aim of robotic-assisted partial nephrectomy is to preserve healthy renal parenchyma in case of solitary kidney, for instance. And it's very a challenging procedure because it's extirpative and reconstructive surgery. So you have to be very careful. You have you need a negative margin. And the kidney is very well vascularized. So you need the shortest warm ischemia time as possible. So this is the same port placement. The only difference is that you use a 12 millimeter accessory port because you will introduce a clamp, a vascular clamp. So 1 case of bilateral WIMS on the left and 2 nodules on the right kidney. So after chemotherapy, you can see that the nodules on the right kidney have almost disappeared. And this is post-surgery and post-chemotherapy. So you have no nodules on the right kidney. But 1 year after, you have a recurrence of this nodule. You can see it very well here. So we decided to do a partial nephrectomy with the retroperitoneal approach. So just to remind you, this is a solitary kidney. So it's impossible for you cannot take any risk of spasm on the renal artery. So you have to be very, very careful. So as the adults have shown me, you don't need to dissect the renal vein. You just need to dissect the artery. So you have to be very careful. And I always put a tourniquet around the artery. Then I put my clamp. So when I put my clamp, everything is ready to do the partial nephrectomy. So you delineate the tumor first, and you have to be very quick because this is warm ischemia, but you have to be very quick, but you have to be very careful not to open the tumor because in this case, this is a WIMS, and you don't want any spillage of the tumor. So you have to be in normal parenchyma, but you don't want to remove too much parenchyma. So you have to, the border is quite narrow. So then you have to close the cone shape defect. So I use the hemlock clip rhinography. So not to cut the capsule of the kidney, I use hemlock clips. And I put some Surgicel fibrillaire. And then I pull the thread and I do a knot to keep the cone shape closed. And then I remove my clamp. So no bleeding. So this case is very interesting. This is a 14-year-old girl who had a liver transplantation for she needs a new liver transplantation, and during the workup, we found a tumor on the left kidney. When you look at the scars of on her abdomen, the retroperitoneal space was the only area in her abdomen with no scar. So we decided to use this approach in this teenager. Recently, I used the prone approach for this tumor. You can see here, this is the kidney here. This is here, you have the peritoneum, and it was very convenient for this posterior tumor. So in conclusion, it's a feasible and safe procedure in highly selected group of children. And when you do robotic surgery for tumors in children, you have to reproduce all the steps of the open surgical approach required to treat the tumor. So you have to respect the oncological surgical principle because you want an excellent oncological results. And when you do partial nephrectomy, you want also to preserve renal function with short hospital stay and a short incision. I just want to show you this case. I have done 3 cases of lymph node dissection for non-seminomatous germ cell tumor. So this is a DSD patient with only one testis, and he had metastasis. You can see here the big lymph node. So after chemotherapy, we did a robotic-assisted laparoscopic retroperitoneal lymph node dissection. So the patient positioning is quite strange because you have to put 30 degrees from the Trendelenburg. So you have to explain your anesthesiologist at the beginning of the procedure that it's safe for the patient. So this is at the beginning of the procedure. You can see the lymph node here. So in this case, you have to do a complete bilateral lymphadenectomy. So this is the result. So this is the ureter, and this is the vena cava and the renal vein. This is in between the renal vein, the vena cava and the aorta. You can see here the right renal artery. This is here you have the left renal vein. Here you have the inferior mesenteric artery. And here you have the iliac vein. So with this approach, this is a very good indication to perform a total lymphadenectomy, and with lymph nodes on the right of the vena cava, in between the vena cava and the aorta, and out on the left of the aorta. And this is the tumor. So the next step is, of course, image-guided surgery. Professor Sarnacki, the head of department, has developed a group called IMAG2 for the 3D reconstruction based on MRI of tumors and pelvic malformation. So now, when I operate the tumor at the console, I have the operating field, and I have the reconstruction in 3D of the tumor. And each tumor is reconstructed based on the MRI, and it's very helpful to do the procedures. I think that in a university hospital, you need the dual console because it's very helpful and it's very convenient to do this procedure at 2 surgeons. This kind of difficult procedure, but if you want to train fellows and other surgeons of your department, you really need the dual console. So at the beginning of my experience, all the procedures were done by Professor Sarnacki and I, and it was really helpful to have the dual console. In conclusion, patient safety is paramount. And I think that the room for error is less in children. So when you do your robotic surgery, you have to be very, very well prepared. If you need to do cholecystectomy, Nissen, just do as many procedures as you need, but then you switch very quickly to complex procedures. And our objective is to expand boundaries and to define new indication of robotic surgery in children. Training is very important. That's why with Hubert and Laurent, last year, we organized a masterclass in Paris for beginners or for advanced to train them how to deal with the robot. And unfortunately, this year, the COVID doesn't help us. So we couldn't do the second session of this masterclass, but it was very interesting to see how surgeons need to be trained in robotic pediatric surgery. Thank you very much.
Thank you very much. Thomas?
Yes?
Thomas, thank you very much. Very nice presentation. And now we start the discussion. Please, you remove your laptop. Okay, perfect. Gloria, you want to start the discussion? You are the discussion of this session.
Thank you, Thomas. It's a wonderful presentation, and I'm very impressed for this new approach for the retroperitoneal space, especially for the modality you use to to have a large view on a cancer, on a tumor, and on in the space interaortocaval. That's new. That's really new. A new approach. It's a good approach. It takes sure a lot of demanding in terms of preoperative evaluation, 3D dimension, a lot of study. I could like to ask you just few comments concerning technical suggestions in approaching the vessels and especially the renal and the artery and this interaortocaval. Remembering that I think that adults, for instance, they use this approach. And actually, they proposed even this approach for transplantation, for donor, from donor to renal transplantation. So it's probably even as in pediatric surgery, we can open new perspectives of technical approach. So I would like to know from you when to use. This approach and how?
So before doing this kind of surgery, you have to go and see the adult surgeons.
Yeah.
Because they have such a huge caseload of patients. They have such expertise. For instance, in Necker, we do 100 cases of pediatric robotic surgery per year. The adult surgeon, they do between 500 and 800 cases per year. So they have a huge expertise. So when I have new indication, new cases, cases that can be interestingly managed with the robot, I call my friends and I ask their point of view. They don't come to visit me to help me, but just I need their advice, their tips and tricks because it's very important. And because to dissect the vessel, for instance, when I do laparoscopy, I always used ligature, okay? I used the Maryland ligature. That's why I started my first WIMS. I try to dissect the renal ileum with the vessel sealers. But the vessel sealers is not adapted at all to dissect the renal ileum. That's why I had to convert my first case. So after this conversion, I went to see a renal tumor in adult surgery. And I have noticed that they do everything with the monopolar curve scissors. So I adapt this strategy. And if it's a good strategy because with the scissors, you can use them as a right angle because thanks to the angulation of the robot, it's very convenient. But step by step, you have to take advantage of the expertise of the adult surgeon. And the interesting thing is that Professor Sanakic, she doesn't do any robotic surgery. At the beginning, she wanted to be trained in robotic surgery, but she realized that to get trained, and especially in her case, she does only tumors. She does only oncology. So by definition, this is the most difficult cases. And at the beginning, she wanted to be trained, but she realized that it's very time consuming, and she preferred to operate with me at the beginning. I do the procedure, but she stays next to me, and she can give me advices how to dissect, how to handle the tumor. Because with the robot, you don't want to have any rupture of the tumor. And thanks to God, so far we had no rupture, because you have no haptic feedback. But with the robot, you see so well the operative field that you don't need the haptic feedback. So working together, it's truly a team building when you do this kind of surgery, because if you do robotic surgery, it's to push the limits of minimally invasive surgery. So you will do more and more and more complex cases. And probably the two cases we had to convert recently, the emergency undocking and the WIMS with liver infiltration, were not good cases to be done in minimally invasive surgery, laparoscopic or robotic surgery. Because the first case, the tumor was too big, and the second case, the infiltration of the liver by the tumor now is regarded as for us as a contraindication. And I think that the retroperitoneal approach for partial nephrectomy, I would have never imagined to do this kind of surgery. But Professor Sarnacki told me, you are very comfortable with this approach. I think that this approach can be very interesting for tumors in children, for kidney. So that's why she pushed me to develop this approach. And we don't do total nephrectomy with robotic retroperitoneal approach. We do this with laparoscopic approach. So I started with pyeloplasty. When you have a polar vessel, you have to dissect the vessel. So you get used to dissecting vessels in retroperitoneal approach with robots. So each procedure you do will help you to do the next procedure. That's why it's very interesting. But my concern now is how to train the fellows to do Wilms tumor with a robot. Because you cannot take any risk, because if you rupture the tumor, it's a disaster for the children. So you have to train very step by step the fellows, and you have to start with older children, smaller tumor in close to the pelvis, close to the ileum, but step by step you have to train your fellows.
Thank you, Thomas. Alfonso Paparella, I have a question.
Yes, thank you to Thomas Blanks for his very nice experience. I have a question on robot-assisted laparoscopic pyeloplasty. And according to your experience, there are other surgery groups that say that should be indicated in patients older than 18-24 months with almost 10 kilograms of weight. And this is the first question. The second, I mean, I don't know if this is a contraindication. I mean, you can do also less in your experience in patients that are weighing less than 10 kilos or not. And the second question is also if you're concerned about suturing the learning curve in suturing with the pyeloplasty, especially in robotics. I think that is easier in robotics than in laparoscopy. Your opinion. Thank you.
So when you do transperitoneal approach, I think that we have done procedure. We have done bilateral adrenalectomy in 4 kilograms babies. We have done Wilms in 5 kilogram babies. So I think that the weight is not a contraindication to do transperitoneal approach. For retroperitoneal approach, under 12 kilograms, you cannot. But I think that if you in daily practice, you do transperitoneal pyeloplasty, you can very quickly go down to 5, 6, 7, 8 kilograms without any issue. And I think that it's much more convenient with the XI, even if the trocars are 8 millimeter. As Quentin Balouet showed, it's more convenient in small space to use the 8 millimeters, the wristed instrument in 8 millimeters, instead of the 5 millimeter instruments. So if you have the XI, don't start with very, very small infants, but very quickly you will see that you can go down to small children. Second question, suturing. The robot it's a dream to suture with a robot, because when I was fellow of Allied Gonemes, I had back pain because of the position of when you do laparoscopy, especially when you do retroperitoneal, the position is not ergonomic at all. And when you finish a procedure, you're exhausted. With the robot, when I do pyeloplasty with the robot, I can do 2 cases per day, and the surgeon is not tired at all because you're so comfortable. And I think that it's very important when you do complex cases, when you do very complex cases, when you know that you will spend the whole day in the operating room to do robotic surgery, being comfortable is very important because you're not exhausted, and I'm sure that you operate better. So suturing, for sure, you can suture 6-0 without any issue, because when you do your knots with the 6-0, you can see the tension you put on the thread, and you don't cut the thread.
Thank you very much. Now, Ernesto Leva has a question.
Yes, Ernesto Leva from Milano. You are having a wonderful anesthetist from Milano working with you. And you have a huge experience about this pathology and this technique. My question is the policy in France to centralize this type of disease? Because in Italy, on a population of 9 million children at the present moment, we are probably running in 10 centers looking for robotic. How is the situation in France, and how is important, in your view, to centralize this type of disease?
So the expertise in France for laparoscopic Wilms tumor started with Professor Varlet in Saint-Étienne, who developed an expertise, and then he trained other surgeons, and he went to assist them in doing such surgery. So there's no centralization of this surgery, but there is a collaboration in between surgeons to do this kind of surgery. And I think that it's very important to communicate together, to work together, to discuss the case together. It's very important. And all the tumor cases are discussed in the tumor board with Institut Gustave Roussy, Institut Curie, and our department, because we really work as a team building with the oncologist. And what is very interesting is that at the beginning, they were a little bit scared about this robotic approach, but now they demand that the children are operated with the robot. So there's a total change in the point of view of the oncologist. So in France, you work with the oncologist because the oncologist send you the patient to be operated. So in France, we are doing a publication with Hubert Lardy and Laurent Fourcade about our global experience in tumors. And we have our 3 centers have operated 100 tumors. And what is interesting is to see that at the beginning, you start with neuroblastoma. Why? Because there's no risk of rupture for neuroblastoma. So it's much more easy to start with neuroblastoma because, but when you do neuroblastoma, when you have vessels involvement, you have to be able to dissect the vessels. And at the beginning, when you don't do neuroblastoma with IDRF, okay, you don't choose patient with image-defined risk factors, but you can see that step by step, your indication of robotic surgery for neuroblastic tumor are more and more complex. And recently, I have operated neuroblastoma, and the renal artery was totally encased in the tumor. And I think that in laparoscopic surgery, it would have been impossible to do. So I had to skeletalize the artery, and at the end, we could keep the kidney, which was very important for the children. And I think that I would have been unable to do this kind of procedure at the beginning. So you have really to go step by step, and you need to ask the help of colleagues that are more trained than you, not to do the procedure instead of you, but to explain you, to be here next to you, to support you, because sometimes you don't know where to go, how to handle the tumor. So it's very important to be supported. The Neymar, the best football player in the world, has a trainer. So all the surgeons should have a trainer to help them to do complex cases. I think it's very important.
Thank you.
Thank you.
I'm not sure that Neymar is the best player.
I'm not sure too.
Okay. The last question, Patrizia Dalligna And after, I want a final comment from Juan Tovar. Patrizia.
Buonasera a tutti. Hi, my name is Patrizia Dallegna, and I used to work in Padova, and now I'm in Bari. My question is related more to the centralization of the techniques more than the disease. I saw that more or less in 4 years you treated like 140 cases, 130 cases, and I think that you are a big center, and the learning curve is reached with the first 40 cases at first, and then 30 cases, and then 40 cases. So do you think it could be wiser to have just a few centers where robotic is used? This is my question. And I have a comment. I work very strictly with Sabine Sarnacki, and of course, in literature there are no papers on robotic surgery, but thank you to all the surgeons. Now laparoscopy has been started for either Wilms tumor and neuroblastoma, and I think that one day this procedure would be perfect for this tumor, even if you, as you said, you need to be careful to have the perfect characteristics for Wilms tumor, like a good response to chemotherapy, and also, for example, for neuroblastoma, not to have the risk factors. Thank you.
So thank you very much for your question. So I think that the number of cases you're talking about was my experience at Robert Debré for pyeloplasty. Because in almost 4 years, we have done more than 330 cases. So roughly we do 100 cases of robotic surgery per year, okay? So it means it's for urology, for visceral, for general surgery, for oncology, for thoracic surgery, for ENT surgery, and for transoral robotic surgery. So it's a big amount of patients. When you compare with adults, it's very small. So I think the best is to have fellows and residents that goes in adults department to be trained in robotic surgery, and they arrive. It's like open surgery. When you are a resident, you go in adult surgery to learn how to do open surgery. You go in adult department to know how to do laparoscopic surgery, and it will be exactly the same for robotic surgery. They have to be trained in adult surgery, and then they go in pediatric surgery, and they have to totally modify the technique to be adapted to very small children and to very large. What is interesting is that we have done in Necker, we have done 75 different indications. And this is characteristic of the pediatric surgery. The adults, they do prostatectomy, cystectomy, nephrectomy, and that's it. But in pediatric surgery, you have many indications, and you do only a few cases for each indication. So it's for each new cases, you have to adapt the room setup, you have to adapt the instruments, the port placement to these new cases. So it means you have to anticipate many things.
Thank you very much.
Thank you very much. The final comment of Professor Tovar.
Yeah, well, I have to say that I was very impressed, Thomas, by this outstanding presentation. I think you made a huge progress in the last couple of years on the care. And you mentioned that when I was visiting you, you had some troubles to find the right position in the retroperitoneal space, but you convinced me because the quality of what you can see through the dual console and all that, I was very impressed by the advantages of robotic approach in some of the conditions you have shown. And I'm sure that will go on and you will enlarge the indications and have more and more experience in that base. Thank you very much. I enjoyed very much your presentation. Thanks, Thomas.
Thank you very much.
Really, I invited Thomas Blanc for a pyeloplastic for a retroperitoneal robotic way, and really the retroperitoneal way is the natural way for the kidney, because the abdominal, the transabdominal is not natural. It's very good because we have a big space, but it's not the normal way, because for a little leakage, we have the retroperitoneum, the peritoneum, and don't have problem. We don't have the uroperitoneum.
Yeah, I fully agree with you. I think you are absolutely right. Yes, yes, of course.
Okay, thank you very much. Now, Gloria, the second presentation for Laurent that write me that don't have problem.
Laurent, I think he doesn't need more presentation. We're waiting for him, so let's go on because probably it's late. Laurent?
Yeah. Yes, I'm here, Gloria.
Yeah.
Can you see the slides?
Yes, we see very well. Thank
Okay.
you, Laurent, because you have a very good diagnosis. It's a firewall of Wi-Fi system of the hospital. This is very interesting because when you have another problem, I don't think this. Please, thank you very much.
So thank you very much at first to invited me at this forum, and thank you, Mario, to keep the link between the surgeons in this time of COVID. And also thank you for Gloria for the presentation. And I have to say that Gloria was also one of the first surgeons really trying to do robotic surgery in small children. And they published a lot of paper in children lower than 3 years old, etc., etc. So thank you very much to welcome me here. So I will talk about a specific focus about the robotic surgery in pediatric surgery. I want to go further on the slides. No, it's okay. So the first question, and it is the same paper that John Bian published in 2009, was, is there a room for this, for robotic surgery in small children? And in this paper that was focusing on very young children, they published results on abdominal surgery and also thoracic surgery. And they performed some lobectomy, segmentectomy, CDH repair, oncogenic cysts, eventuation, tracheoesophageal fistula, and cystic hygroma. So the problem is not new, and John Meehan published at the beginning it was possible. Like Thomas said, first it is patient safety. For Thomas, it was at the end of these topics. For me, it is the second slide. I think if we want to do some thoracic robotic pediatric surgery, you have to take care of the safety. And first of all, you have to take in the theater the thoracoscopic material, also a thoracotomy box in the operative room, because you are always very close from the large vessels, from the heart, from the aorta, and you have to be sure that you can, in case of conversion, do the hemostasis. You have to be really trained, and you have trained all your team, not only the surgeons, but also the anesthetists and all the nurses, the scrub nurse, and everyone inside the theater. And especially, we will see that later, you have to train the people to the emergency undocking. That means to remove quickly the robot from the very small child. Anesthesiologists will discuss about that because we are doing surgery in a very tiny area, and for them, they have no access to the head of the patient. So you have to also to discuss with them, but once usually the surgery began, they have to do nothing, but we will see, like Thomas showed us, it's not always very calm. The communication, it's also very important. You have to do a loop communication because the surgeon is not close to the patient, to the bedside. He's on his screen, on the console, and you have to discuss with everybody around you. So what does it mean, loop communication? You ask a question, you have to have an answer dealing with your question, and then you have to close the loop with somebody like something like thank you or what else. It's very important, especially in case of emergency like we saw before. And at the beginning, and we are we are doing that again at this time, even after a few years of experience. We created a dedicated checklist to be sure to don't forget any dispositives, any devices. And at the beginning, we came, because our robot is not at the pediatric surgery hospital, it is in the adult hospital. So we have to move on. And the day before the surgery, we move on very light after the urologist finished their procedure to simulate how was the location of the robot, how was the location of the child, etc., with the anesthetist, with the nurses, to be sure that at the day of the surgery, all occur very quickly. So, robotic surgery for esophageal atresia in neonates, is it possible? Esophageal atresia, there is plenty of discussion about that. Should we do a classical thoracic approach, thoracotomy approach? Should we do thoracoscopic approach? There is a lot of debate. So we performed once. It was 7 years old, 7 years ago now, and she was not a very small child like usually. She was 3.2 kilograms, so it was a good case. She was at term. She was not a preterm baby, and we did the surgery after we performed around 50 cases in pediatric surgery and in small children. But for me, it was my first case, even in thoracoscopic surgery. So this is the location of the child. The little girl was quite prone position by this way. And for the nurses, it was very challenging to do a safe docking. It was we still have this old robot. The SI was not the XI. So you have to have a little space here at the bottom of the bedside to put the edges of the cart and don't push the anesthetist material here. Then this is the space where we did the surgery. You have the huge bazooka, the huge camera. It is the 8 millimeters, it is the 30 degree with two robotic ports and an accessory port here. So there is a lot of ports in this small child. This is a short movie summarizing the different steps of these procedures. First, like in open surgery, we coagulate the azygos vein. And even the instruments are large with the double wrist manipulation and the small size inside the cavity, it was possible to do the surgery. So this is the fistula. I put a loop around and it was possible to do stitches. I really prefer to do stitches than to put a clip because I think the risk of recurrency of repermeation of the fistula is really lower with stitches than with clips. This is the lower part of the esophagus. Perhaps it's not useful to put some thing because it is sterile under the carina, and we cut it. The dissection of the esophageal upper pouch with the help of the anesthesiologist pushing on the gastric tube inserted in the upper pouch of the esophagus. It is a blunt dissection, there is no bleeding. And in the true life, it is like we are doing surgery in a small matchbox. It's very, very tiny. This is the upper pouch. I cut perhaps too much. When I saw the video retrospectively, perhaps it was a little too much, but it was possible to do an anastomosis. It was not a long gap esophageal atresia, it was a typical type 3. So it was possible to do the anastomosis without too much tension and without any leak during the surgery. This is the anterior part, and we finish. We pass the esophageal, the gastric tube inside, and it was a successful intervention. And after that, I came to the first meeting about esophageal achalasia in Montreal, and I did a publication just after Steve Rothenberg. And I think if he could kill me, he will do that, because he is doing esophageal achalasia with thoracoscopic in 3 millimeters. And if you see, with thoracoscopic, there is limited instrument movements, less accurate suture. It's performed only by experts, because if you see, if you read the literature, there is just only not more than 10, 15 centers in the world doing thoracoscopic surgery for esophageal achalasia. But you have a magnification of the operative field. You keep a good aesthetic aspect of the skin, and there is low postoperative pain. And if you compare with thoracotomy, you have to deal with the length of the incision, cosmetic consideration, but you have a good quality of anastomosis with a low rate of stenosis, and it is teachable, what is very difficult to do with thoracoscopy. So in my mind, after this first case, Robot combines the two advantages, both of thoracoscopy and thoracotomy. We did 2 other patients, but with failure. The second patient was a small little boy, 3 kilograms, and it was in fact a ventilation tube displacement inside the fistula. So for me, I was very comfortable during the small minutes because there was no hair in the lung. But for the anesthetist, and hopefully I was not alone, a very experienced surgeon was close to the bedside and could say to the anesthesiologist, there is perhaps a displacement of your tube, you have to take care. And we undocked, I have the video in 10 seconds to convert in a thoracotomy. And now the child is safe. And a smaller child, little boy again, but I think that with the size of the instruments, that means 8 millimeters, it was really too large. And when I move the ports, I move always the child. Perhaps I put the ports too close to the spine, but anyway, it was not a minimal invasive surgery. So I converted to an open procedure. So I think that the robot would be a very good device, tool to do this kind of surgery, but we have to wait a little to have reduction of the size of the instrument. What we can do also in thoracic surgery for the children, there is the CDH. So for the newborn, it could be very useful, but we have the same limitation than with the esophageal achalasia, the size of the ports, the size of the robots, and most of the time you have to do the surgery not in the pediatric theater, but in the ICU or elsewhere in another hospital. So it's very difficult to move this child with all this very tiny and very taffy ventilation in another place. But I think it's possible. I will show you for late discovery CDH, like in this movie. It was at the beginning of the experience, and I began, in fact, with 3 millimeters instruments in classical thoracoscopy because I was a little scared about the spleen. I didn't want to do injury of the spleens, so I began with classical thoracoscopy. And then we put the robot. She was 1.5 years old, and it was very easy to do this surgery. At first, I put stitches without pledget. Perhaps I was a little too much aggressive, and there is some leakage here, some tears on the muscle. And then with the pledget, taking the ribs or not, it was really possible to close this small defect. It was not a huge CDH, but it was a true one without any sac. And you can see even in a small space, with the maniability of the instrument, it's easy to stitch inside the pledget to not lose it inside the abdominal cavity, etc., etc. You have not the haptic. That means that you can't feel the the strands you put in your instruments, but with the good view, with the three-dimensional view, you can see on this stitch here, all the fibers that will be very, you can see and stop the strands before the rupture of the stitch. So for CDH, I think that it could be possible, feasible, but not for the very young children because of the lack of a small device. Bronchogenic cyst, it is also an indication to do thoracic surgery. Is it esophageal duplication, bronchogenic cyst? The pathologist will say at the end, but it's also possible to do that, to remove this kind of cyst. At first, you have to avoid to do any little hole. You have to do the surgery with the whole cyst. And you have to stay, if you stay very close to the cyst, it's possible to do the surgery, avoiding any injuries of the large vessel around and other problem. Then you put a needle to empty it, and you can remove it by the port. So I think that for the bronchogenic cyst, it's a good and safe device. This is another important matter of fact in pediatric surgery, the lung resection for CCAM or sequestration. And if you read the literature, I know there is some debate, but most of the all, you have to do the surgery quite early in the life of the child. That means when the child will be around 5 kilograms, around 6 months, it's depending, but you have to do that. And if you see Arnaud Bonnard, for example, he can do that with 3 millimeters instruments in less than 1 hour in decades hospitalization. So he's an expert. But with the robot, we have no case because it's not safe to do. We will see that later in a few slides, that to do this surgery, this resection in so small children, it's quite dangerous and it's not useful. So we have the same limitation than for neonatal thoracic surgery, esophageal achalasia, and CDH repair. You can see, but Hubert talk about that, of the difference of size between 8 millimeters and 5 millimeters. Once you are inside a cavity, the 8 millimeters are a little smaller than the 5 millimeters. I know that Gloria is not totally agree with that, but anyway, we can show that on this picture. Thymectomy, sometimes there is some indication, and in this study, it was not children, it was adults, but it seems to be possible also to do the robots with with no blood loss and the same day of chest in tube days. It's a little dark, I'm sorry, but it is a little girl. She was 10 years old and she has an osteosarcoma of the femur. And after the surgery, after the chemotherapy, and after all, 2 years after, it was this apparition of this image here on the ribs. So we did a ribs biopsy using the robot. So you are really on the good location directly. And it was possible using the robotic instrument and also the Kerrison instruments used for the spine surgeons to remove it without too much scar. And at the end, it was good news. It was not a recurrency. It was just an artifact. It was just exostosis without any link with the tumor. Hopefully, we put that in the bag. And then it was possible to remove that. So you can also, and François Beckmer in France published about thoracic bone surgery. With the robot, you can also do this kind of surgery. So if we want to summarize what we can do and if it is safe and possible, there is this paper we published with also with Hubert's team and Quentin about the assessment of pediatric thoracic surgery. And here are the experiences of what we did. It's what we talk about. We have also the LR myotomy But it's possible there is a high rate of conversion for esophageal atresia. Also, I did a right CDH. It was not possible because of the lack of the size. Shall we begin with robotics pediatric surgery? Definitively not. You have at first to be trained by the adults, like said Thomas, or by classical surgery, and at first on the lab and then on the children. But on the 96 first procedure we published with also Hubert, we just did one surgery on concerning the thorax. We did general surgery, urology, but the thorax, we didn't begin with that. We wait to have a lot of experience or a small experience on this topic, but it's not safe to begin directly with thoracic robotic pediatric surgery. Is it an easy procedure? When you see in the study comparing the results of robotic surgery in children weighing above and below 15 kilograms, you can see that all the conversions occurs for the thoracic surgery. So it is not easy, and perhaps we did too much with this device, and now we stop to do esophageal atresia with the robot. We are really waiting for a better device to do that, even if it is a pleasant surgery. The main problem is that at the difference of the abdomen wall, abdominal cavity is distensible, but for the thoracic cavity, it is very stiff, and it's very difficult to insufflate it, to expand the cavity because of the ribs, and just the insufflation is good to remove, to crush a little the lung, but that's all. And you are doing surgery in very small cavity. Another point, it is this study, and it's a study published by Guillaume Potvin, a national French study, that wanted to compare the results of the occurrence of a scoliosis for the children operated with classical thoracotomy and with thoracoscopic surgery. And you can see that there was a very higher rate of sequela with classical thoracotomy than with minimal invasive surgery, that means thoracoscopic surgery. And I have to say that the girl who did the surgery with the esophageal atresia surgery with the robot, now she's 7 years old, and she has a scoliosis. It was not a bacter, it was isolated esophageal atresia. And when you put this large port of 8 millimeters between the ribs, you are sure to destroy a little these ribs. And I think because of this reason, it's not safe to do this kind of surgery in very small children. So as a conclusion, it is not for beginners in robotic surgery. Don't begin with that. You have to check about the security, classical thoracotomy instruments in the operating room. Another second experienced surgeon, it's not only a fellow that could be useful, but like with Sabine Sarnaki-Necker and Thomas, you have to be with another experienced surgeon. And I think that above 10 or 15 kilograms, it could be a good device for children. That means for the majority of our indication in thoracic surgery, it's not a good device. We have a high rate of conversion. It's not mini-invasive. That's true. And so we stopped robotic indication for these children. And we still are waiting and advocated for the miniaturization of the whole system. Thank you very much.
Thank you very much, Laurent, for your nice presentation. I open the discussion. Any question? Ernesto, what do you think?
I think that for esophageal atresia, with the instruments that we are having now, it sounds very difficult to do this operation. And probably thoracoscopic approach in certain cases is indicated, but mainly I think that open surgery is still the best, in my view, in my experience.
Really, I think is very correct the conclusion of Laurent. Let's say what is now the limit of the weight, and the limit really what is the instrument, the size of instrument. And I agree exactly what say Laurent, because probably in the future, when we have the instrument of 3 millimeter with that work like robotic mode, I think is mandatory to the use of this. But now it's very difficult. What is the opinion of the other colleague? You have a question? Another question that we treat in the all three presentation is the centralization of these patients. And Giovanna said me the opinion of Giovanna. Please, Giovanna.
Thank you, Mario. So I think I would like to underline what Thomas Blanc said, that we are a community. We can join our effort, asking some mentor to help us. But I think that regarding robotics, we are obliged to train all our trainers, because this is the future, in surgery and also in many fields of pediatric surgery. So I think that the idea that some center has to do robotics and others not, is not a good idea for the future, for developing pediatric surgery globally. I think we are obliged to learn robotics to our trainers everywhere in all centers. And we may ask some help to the real experts, but this is one of our, tool for the future.
Professor Tovar, what is your opinion about this argument? Because it's a very actual argument for the new generation. Because
I fully agree with you what you said. I think the main problem is that the equipment is too huge, and until we can miniaturize all the equipment and use that in small babies, I think we will be limited by the weight, and we will be limited by the size of the patients. But I agree with also with you. I think that that's the future. That's we have to go through that, and I think we have to make everything we can to train young people on that, because I think this is going to take a place in our specialty quite soon from now. Yeah, I agree with that.
Laurent?
Yes.
Okay. Any questions for the audience? Gloria, you want the final comment of...
Well, I want just to say, just to collect all the ideas you are saying now, that the robotic surgery is a particular surgery, and could, in my mind, I think it could become a good moment for training for new generations, for fellows and so on. So it could be introduced during the training of all new surgeons, because in robotic surgery you learn to stay long time in the same space, and you have to stand in front of this space and to find all the ways, all the manner to perform surgery. So robotic surgery learns as a new way, a new image of that specific space. It could be the pelvis, the upper abdomen, the renal space, and so on. And robotic surgery leads to another approach to the patient, that's simulation. Simulation in preoperative way, in preoperative time, simulation of the images and simulation of that space. And it's a good way to collect all the equipe to warm the terms of cooperation of the equipe. So is a good moment for learning and for growing in terms of technical advances. And it's also a moment, an important moment to review the preoperative images, because long time you have to stay to know very well the small space, small surgical space. So the reconstruction of these images, especially in small babies in preoperative times, is very important to move in this way. Robotic surgery is really an opportunity for brain activation, and that's described in the literature. And brain activation is different in robotic time instead of laparoscopic time and in open surgery. Every type of surgery needs and allows to a different brain activation. It seems that robotic surgery is the most complete form of neural activation, activates the lateral, the frontal part of the cerebellum, the cerebral parts, and so on. And a particular part of the neural brain that's so-called the mirror cells that are collected, especially in the lower part of the cerebral tissue. So I think it could become really a moment, an important moment for teaching for all, for youngers and for oldest, and because it really opens to new perspectives of treatment, and you are exactly seeing this thing with the new perspectives of surgery you presented today. You are saying exactly these things. So thank you very much.
Thank you, Gloria. Thank you, Hubert, Laurent, and Thomas for this very interesting afternoon. The next meeting of Club 15 is the 30th of September, and we have the clinical case. Bye-bye all, and to the next appointment. Arrivederci.
Thank you very much. Good afternoon.
Good afternoon. Thank you very much. Arrivederci.
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 Grazie.
Arrivederci. Thank you very much.
Grazie.
Leave the meeting. Ti ho lasciato.